keep to our timelines, I think we'll begin. I'm just going to begin by sharing my screen. And I'd like to welcome everyone to our Fall 2021 Education Series, aptly named Forward Thinking About Posterior Stroke. I'm Ingrid, and I am the Regional Rehab and Community Coordinator with the Central South Regional Stroke Network. And I'm very pleased to act as your host today and to welcome you to Part 2, Management of Posterior Stroke Syndromes. I would like to let you know that today we are working together to have our two presenters, Dr. Jim Salas and Dr. Florin Feliu, present to you. But before we do, I did want to let you know that we are recording this session. So if you are not comfortable with that, please stop your camera and de-identify yourself. And we will be posting the recording on our Central South Stroke Network. I also wanted to let you know that this session wouldn't have been possible without our education committee. And we have a significant group that has come together, both from the regional team and within our different sites, pulling together to make today possible. So at this time, I am going to stop sharing and introduce you to our first speaker, Dr. Jim Salas, who is an associate professor in the Division of Neurology at McMaster University, and he also serves as the clinical lead for stroke prevention in our Central South region. He completed his fellowship training in behavioral neurology and is actively overseeing multiple clinical trials in both stroke and dementia at Hamilton Health Sciences. Jim's current research interests include pathways in management of carotid artery disease, the role of neurosynology, and vascular cognitive impairment. I'm very pleased to ask Dr. Salas to present, and the title of his presentation is Understanding Posterior Circulation Stroke. Dr. Salas, I'll turn it over to you, and thank you.
Thanks very much. So it's a pleasure to speak to so many people. I will pull up my slides. Let me try to screen share here. Go. Screen. There we go. Okay, so I think people should be able to see the title slide there. Understanding Posterior Circulation Stroke. There'll be a little bit of overlap with my own talk and Dr. Feliu's. Obviously, we're discussing different aspects of the same subject, but as we were stating just before everybody came on, a repetition is good. So especially when dealing with posterior circulation stroke and the brainstem and so on and so forth. These are the objectives that were shared with people earlier. So I'm going to attempt to convey an understanding of the sources, the etiology of posterior circulation strokes. I'll give you examples of how imaging can be used to better understand posterior circulation stroke sequelae and presentations. And then lastly, I'm going to cover some of the major posterior circulation stroke syndromes. Well, there'll be time at the end for questions. I think I'm going to try to pace. Sorry. You'll hear that, I guess. All right, so I'll try to go slowly. I'm happy to take some occasional questions during the presentation. I've tried not to pack too much information in there so that we can go at a nice pace and still at the end to ask broader questions. Okay, so here is a schematic of the brain and the posterior circulation. So you see at the bottom the brain stem. The brain stem, I want to make sure people can see the pointer. Can people see the little arrow? Maybe someone give me, oh, good, good, okay. So here is the posterior part of the brain. You see what looks like cauliflower is the cerebellum. And then in front of it, you see the brainstem. And the bottom part of the brainstem is called the medulla oblongata. We don't really say oblongata usually. We just say the medulla. This is the pons here in the middle. and then up top is the midbrain. And so the circulation to these structures are the vertebral-basilar system. We call it vertebral-basilar because it's comprised of the two vertebral arteries. Here's the one, and then here's the other. And you can see that the two vertebral arteries join to form the basilar artery. And it's called the basilar artery because it goes over, in Latin, they called it the basis pontis. So over the base of the pons. Then at the top, it splits into the posterior cerebral arteries, which go to the occipital lobes. And one thing I didn't really talk about very much is PCA territory syndromes and occipital lobe stroke. Thematically, I was just going to focus more on brainstem and cerebellum, but we can certainly cover the PCA territory strokes in the end if people would like to. In terms of the main branches off of the vertebral-basilar system, there's three cerebellar arteries. So starting from the bottom, there's the pica, or the posterior inferior cerebellar artery. Then right after the two vertebral arteries join, there's the aica, the anterior inferior cerebellar artery. So there are two inferior cerebellar arteries, a posterior and an anterior one, the pica and the aica. And then up the top, just before the basilar splits into the two PCAs, there is the one superior cerebellar artery coming off either side. So they're paired, obviously. So there are two picas, one coming off each side. There are two aicas, one coming off each side. And there are two SCAs, I guess, superior cerebellar arteries coming off each side. The only other things to note here are the anterior spinal artery. We're not going to talk about that very much today, but just as the posterior cerebral arteries going to the occipital lobe was a little bit beyond, I think, the scope, although we can talk about it. The anterior spinal artery and spinal infarcts, I thought, also was a little bit below the scope. So I'm not covering those two areas, but we could certainly tackle them if there's time. Lastly, do you see right here, off of the basilar artery, there are these penetrating arteries. So these are Pontine penetrators, and they just go deep. They don't finish here where you see them kind of disappearing. They kind of penetrate into the pons, and they supply the deeper structures of the pons. So that's an overview of the posterior circulation of the brain and the posterior fossa structures, namely the cerebellum and the two cerebellar hemispheres in the brainstem, are all posterior fossa structures. The occipital lobes are not posterior fossa. They're actually above the deuterium, so they're not posterior fossa. Okay, so that's the vascular anatomy for the talk. Everybody still with me, hopefully? Okay. So let's talk about etiology. So etiology is not that difficult. There's four main categories. You can have a stroke from small vessel disease, from basilar, and by that I mean those penetrators that I pointed out to you, from basilar artery disease, so from atherosclerosis within the basilar artery. Thromboembolic disease, what that refers to is a thrombus rupturing somewhere proximal to the arteries I showed you, and then with that, a plaque rupturing and forming a thrombus, which then embolizes into the posterior circulation, or cardioembolic. We can do basilar artery thrombectomy. It's interesting to share with people that basilar artery, oh, it's difficult to hear me? I wonder if it's the microphone. Maybe I'll just speak louder. Is that better? I will speak louder. Okay, thank you for the heads up. Okay, so you've heard of endovascular thrombectomy for the middle cerebral arteries, the MCAs, and so forth. So we have evidence for endovascular thrombectomy from the MCAs. We've got multiple clinical trials. So there were a couple of clinical trials that were looking at endovascular thrombectomy from the basilar artery. And we ran into a bit of a problem because it really seemed to be effective. And so what happened in both of these trials is that the people involved began to feel very uncomfortable randomizing people to no thrombectomy. And so both trials stopped because the investigators felt that this really was helpful, and they just didn't want it on their conscience to randomize someone to no treatment. The problem being is that neither trial finished with enough power, to provide us with evidence that this is helpful. So we still do basilar artery thrombectomy, lacking the evidence, understanding that the trials that were being done were trending towards a benefit, but they both stopped prematurely. And then finally, thromboembolism is when you have a plaque rupture proximally, as I said, and cardiac embolism is when you have a clot forming the heart. Now, when I was in medical school and residency, there was this funny urban legend or there was this myth that you couldn't get a cardiac embolism to the posterior circulation. Now, is anyone else here old enough, or has anyone heard about that? Maybe put up your hand or anything? No? Oh, you have, Rhonda? Okay, good. Yeah. So I remember I was reviewing a case and there was a stroke in the posterior circulation, and it's like, well, it can't be cardioembolic. I'm like, why not? It's like, well, because clots from the heart don't go to the posterior circulation. And I'm like, okay, well, if the blood's going to the posterior circulation, why wouldn't a clot go? Like what? Why? So I asked the stupid question, well, why don't clots go up the posterior circulation? And I was told they just don't. And I'm like, doesn't sound right, but I don't know. What do I know? So I guess, it's so funny how these ideas begin and then they're eventually they evaporate. So basically, you can certainly have a clot go up the posterior circulation, and you can certainly have a stroke from a fib or whatever into the posterior circulation. Most of the blood, 2/3 of it goes to the anterior circulation, maybe a third up each internal carotid artery, but the last third goes up. So maybe it's less common, but you can definitely have a stroke from a cardiac source. Okay. So let's talk about cerebellar stroke first. So we reviewed on the anatomy, the three main cerebellar arteries, the superior cerebellar artery up top and the two inferior cerebellar arteries. So here's a side view of what the vascular supply looks like. And it can get a little complicated when you're looking at slices of the cerebellum to think, okay, well, is this a superior cerebellar stroke or a posterior inferior cerebellar stroke? Because depending on what slice on the CAT scan you're looking at, you might be in the superior cerebellar artery territory, you might be in the anterior inferior cerebellar artery territory, or the pica. So it's really hard looking at a scan. Here's another schematic. Which cerebellar artery is it? Well, if you're down low, it's probably the posterior. If you're in the middle or higher up, it could be the so looking at a CAT scan and not being sure what level you're looking at, it's hard to know which one. It doesn't really matter though. Here's a CAT scan showing cerebellar infarct, and we see a little bit of hemorrhagic transformation even here. So most cerebellar infarcts present the same way with ipsilateral ataxia. So you will typically get arm and leg ataxia on the same side as the cerebellar stroke. If the stroke involves the midline of the cerebellum, naturally you'll get midline or truncal ataxia as well. And there are little cerebellar homunculi where it looks as though their back is along the vermis and their limbs go into the cerebellar hemisphere. But cerebellar strokes can be patchy, and they produce varying degrees of ataxia in the limbs on the same side as the stroke and the trunk. And it's important to know that there are two other manifestations of cerebellar stroke that are important from a speech point of view. One is a scanning speech that people can develop with a cerebellar stroke. A scanning speech is speech where you don't have inflections and speak kind of like in a monotone. It's because your inflections of your speech are modulated by your cerebellum. So you can lose those inflections and sound kind of emotionless when you're talking if you've had a cerebellar stroke. It's called a scanning speech. I tried to simulate it there. And the other thing is cognitive. So that's sometimes overlooked. People think the cerebellum as a cognitive organ. It's true that you don't often see the cognitive impact of a cerebellar stroke, but it does exist. A lot of your memory for actions, riding a bicycle, playing the piano, it's cerebellar memory, a lot of it. And you can have even other manifestations of cognitive difficulties with cerebellar stroke. So even from an OT perspective, I'm sure there are many occupational therapists who have ascertained a cognitive impact from a cerebellar stroke. You can have that. Okay, so here is a cerebellar stroke on MRI. This is a diffusion weighted sequence, which shows the area of fresh infarction in bright white or hyperintensity. And you can see that not only is the cerebellar hemisphere involved, but also the lateral medulla. This is the cerebellum at the level of the medulla. And so you can see that the lateral medulla is also affected. So the reason I show you this slide is to make the point that a cerebellar stroke might be purely cerebellar, but it also often also involves the midbrain, not the midbrain, the brainstem at one level or another, often the medulla. So when you're looking at the entire clinical presentation of the person, it's going to involve symptoms not just from the cerebellum, but also from the brainstem itself, from the medulla. So I thought that we could then segue into medullary stroke. And I'll focus on the two main types of medullary stroke, the lateral medullary stroke, that's what's shown here, a lateral medullary stroke, and the medial medullary stroke. So the one we call Wallenberg syndrome, I'll touch on that. Key thing about Wallenberg syndrome is there's a lot of sensory and other symptoms, but there's minimal or no weakness. So really, a lateral medullary stroke, i.e. Wallenberg syndrome, typically you don't get weakness. Medial medullary stroke, however, also called Dejerine syndrome, but I don't know that people really use that term a lot, does cause weakness. It causes weakness on the contralateral side of the body. And I'm going to give you an anecdote about that. Also tongue deviation. I think I'll give you the anecdote now. So the thing about a medial medullary stroke that's interesting is that the weakness can be quite profound, because the stroke is happening at the level where all of the fibers are exiting the brain, right where the medulla goes out through the foramen magnum, right there where all of the motor fibers are concentrated into a very tight little bundle. That's where the stroke occurs, and you can have profound arm and leg weakness. So why I'm telling you this is that people can present with a stroke with profound arm and leg weakness, and they will present with acute symptoms, and they'll be given thrombolysis. The next day, they still have profound arm and leg weakness, and we repeat the CAT scan and it's negative. It's like, I don't understand this. Like, how can there not be a stroke? This person has profound arm and leg weakness. They're hemiplegic. Like, how can there not be a stroke? So the thing is, on a CAT scan, it's really hard to see a medullary stroke. Clinically, the clue is that when somebody's presenting with a medullary stroke, it's even below the level of the facial and nerve. So there's no facial weakness whatsoever. There's no facial weakness, and there's no cortical symptoms. So there's, for instance, if it's right hemiplegia, there's no language problem. If it's left hemiplegia, there's no neglect, right? Because those are cortical symptoms from up above when you have the MCA territories involved. There's not, anything. There might be dysarthria, and people might think there's a facial droop because of the tongue being affected, but usually it takes an MRI to actually identify the stroke. So that's my little story about medial medullary strokes. Okay, so here is another example of a lateral medullary stroke on an MRI, a flare-weighted sequence. And we're not going to go through the whole Wallenberg syndrome because people really just, go, oh my God. So bottom line, I put the list up here, but I'm going to share with you a couple of key things. So Wallenberg syndrome in isolation. So we're not talking about a cerebellar stroke that also involves Wallenberg syndrome. We're just talking about Wallenberg syndrome alone. People often present with vertigo and nausea and vomiting. So people think, okay, could this possibly be vestibular disease? Like, could this be an inner ear problem? Because the primary presentation is actually vertigo, nausea, vomiting. But in my experience, people with Wallenberg syndrome, they vomit. Okay, so they vomited on me, all over me. So like basically, a person with vestibular disease, yeah, there'll be some vomiting. But in my own personal experience, this is anecdotal, this is my personal experience. When I've been in the emergency room and somebody's been lying in a stretcher and I've been asked to see them because of dizziness and could it be a stroke, and I've raised the head of the stretcher because it's flat, so I want to raise them. More than once, when I've raised them, they vomited everywhere. The first time they got me, never, but only once. They've never gotten me again. So basically, if somebody has a low threshold for vomiting, then you gotta think, could this be Wallenberg syndrome? Now, some of my colleagues will disagree with me and say, oh, you could have vomiting with inner ear disease. Yeah, you can, but I think it's something that makes you think, Now, the other thing about Wallenberg syndrome, you can have an ipsilateral Horner syndrome, and I have a picture to show you. And the other key thing about it, if you can't memorize this list, just remember this one thing. You have sensory loss on the ipsilateral side of the face and the contralateral side of the body. It's a crossed sensory deficit. That is the main thing about a Wallenberg syndrome that you could hang everything else on. Okay, so it's sensory loss on one side of the face, the same side as the actual stroke in the medulla, and the contralateral side of the body, because it's, and I'll show you on the anatomy why that is. So it's a cross sensory finding. So I've actually made, I've reviewed a case with a resident and they're not quite sure what's going on, and they've examined the patient. They didn't do a careful sensory exam. My other point to residents is, if you're going to do a sensory exam, do it at the beginning, not at the end of your exam, because people don't care by the end of the exam. They're not going to really be thinking and paying attention and telling you, is this sharp or dull? But I've come to the bedside and I've taken a broken tongue depressor and I've just touched the patient on each side of the face. Does this feel the same on both sides? And they go, no. What's the difference? I don't feel it on this side. Okay, and then what? Can you feel this? Yeah. Does it feel the same? No. What's the difference? I can't feel it on this side. I go, Wallenberg syndrome. Right there. That's the only thing I did. Okay, so it's this crossed sensory finding. That's the main thing. Now, what else can you get? Look at the list. The main thing from a therapist point of view is sometimes you can get real problems with dysphagia lasting for a very long time. For such a small stroke, I've seen people requiring even a PEG because they can't safely swallow for months. Again, in my experience, seeing people in follow-up, nobody's been permanently disabled from their swallowing. I think eventually I've even seen the PEGs get reversed, but it can be pretty bad, the dysphagia. So I just wanted to share with you some, I think, the key clinical aspects of Wallenberg syndrome while I have this list up for you. Here's Horner syndrome. So it's this meiosis, or the smallness of the pupil with the pseudotosis. It's not really a pure ptosis. It's actually shrinking of the lids. So you actually, if you look carefully, the lower lid is also a little bit higher than the other side, as well as the upper lid being a little lower. So the whole eye kind of closes a little bit. And also you have anhydrosis is the other aspect of Horner syndrome. So that's what Horner syndrome looks like, because in Wallenberg, the fibers pass through the medulla. And so here's the medulla. So in color here, we have the main tracts that are affected in Wallenberg syndrome. So in blue, that's your fifth cranial nerve, your trigeminal nerve. So that's what affects, and it goes straight out of the brainstem, right? So if you have a stroke affecting the lateral aspect of the medulla and it's affecting the trigeminal nerve nucleus, you're going to cut off the sensory supply to the ipsilateral side of the face. But then you also get the lateral spinothalamic tract affected, which crosses when it exits the foramen magnum. So you actually have sensory information from the contralateral side of the body crossing over to the other side of the brainstem when it goes to the brain, getting hit there. That's why you have the cross sensory finding. So if you hit this side of the medulla, you're going to knock out ipsilateral spatial sensation, because the trigeminal nerve goes right out of the face, straight, and you're going to get contralateral sensory loss below the neck, because the lateral spinothalamic is coming up from the other side and crossing over. Okay, so that's the lateral medullary syndrome. Now, this is your medial medullary syndrome. This is a patient that comes in with terrible hemiplegia. You think there must be some major stroke, and it's not. And the CAT scan's negative ×2. You're like, what's going on? And once or twice, even the MRI is read as negative, because rarely, I haven't seen it here for a long time, but rarely, because it's the very bottom slice, because it's the very bottom slice. Sometimes it's on the lowest slice of the MRI, and rarely the radiologist has missed it. So have a quick, and it's sometimes not as obvious as this. So basically, that's what it looks like. And why does it cause the hemiplegia? So here is the lower medulla, a little diagram. So in bright pink here, we have the pyramids. So what are the pyramids? They are the descending corticospinal tracts. Okay, so these are where the commands to move one side of the body are passing through. And again, when they pass through the medulla, they cross over to the other side. So if you hit it, you get contralateral weakness to the side of the stroke. And at the same time, here in, we have the 12th hypoglossal nerve right in there. It's not in color, it's just right there. And so that's the 12th cranial nerve, if you recall, moves the tongue. So if you have weakness in one side of the tongue and you're asked to stick out your tongue will point to the side of the weakness. So, you know, if a person has a medial medullary stroke on the right medulla, they'll be weak on the left, densely weak left arm and leg. Dense looks like a big stroke. Face won't be weak, but they might be dysarthric. Why? Because their tongue's a little weak. So they stick their tongue out and it goes that way. It points to where the stroke is because that side of the tongue is weak. So the strong side, the normal side, pushes it over. So if you see somebody in the emergency room, now when I see somebody with really bad arm and leg weakness and no facial weakness, and a touch of dysarthria, I ask them to stick out their tongue. And if it goes this way, I think we're dealing with the medial medullary syndrome. Okay, so that's medial medullary syndrome. I will take a break because that's a lot of information already. We're on track to finish on time. Any questions right now about either cerebellar or medial medullary? Keeping in mind we will have time at the end, but any pressing questions? Now we'll keep rolling. Okay, so we're gonna cover the pons and the midbrain, and then we'll stop. So Pontine stroke. So there's tons of Pontine syndromes. I actually have a slide here showing you all the different Pontine syndromes, but just to make it easy, let's talk about the two main categories. There's the paramedian Pontine stroke, which is a stroke in one of those paramedian penetrators, and it causes weakness, contralateral again, and diplopia because it affects cranial nerve 6, one of the cranial nerves that move your eyes left and right. And then there's actually all kinds of deeper, we call them lacunar or small deep Pontine strokes. And that's various combinations of usually, again, hemiparesis, and you can even get crossed facial weakness. So again, if you see crossed neurological signs, Wallerberg, remember we talked about the cross sensory being the hallmark. Some Pontine strokes, you could actually have facial weakness on one side and weakness on the other side of the body. I haven't seen it much. It's almost theoretical, but you can have it. And I'll show you how. So there is a paramedian Pontine stroke on MRI. And why is it called the pons? I'll just take a little break. Why do you think the pons is called the pons? I'm just going to ask people why they think. What's it Latin for? In Rome, is there Pontine something?
Pons means puente, puente means bridge.
Bridge, exactly. Pons means bridge. And so the early anatomists, when they looked at the pons, these are the medial cerebellar tracts. It looked like a bridge. They're in kind of pink. It looked like a bridge from one side of the brain to the other. So they called the pons because the middle cerebellar peduncles look like a bridge. So that's why the pons is called the pons. There, you know, some neurology trivia now. So let's go into the actual cross-section of the pons. For the medulla, I showed you upper and lower medulla. For the midbrain, I'm going to show you upper and lower midbrain. For the pons, I'm just going to throw you one slice right straight through the pons. So what are we looking at? Here's the bridge. So if we're looking at the pons, so the bridge is now on the bottom. Okay, so you see there, here, these are the middle cerebellar peduncles. Okay, so this is the bridge. Okay, and so what goes through the bridge like this? Okay, so here's the bridge of the pons, and coming down right through the bridge are the corticospinal tracts. And we're seeing them in cross-section here, all these little circles with the dots in them. These are the descending corticospinal tracts. So if you have a stroke bang right here, you're gonna have hemiparesis on the other side of the body because those descending fibers cross when they get to the bottom of the brainstem. So you're going to have contralateral weakness. And depending on where it is, here's two of the cranial nerves, right? So this is the abducens nucleus here, the sixth cranial nerve coming out this way. And then this is the facial nerve in blue. It does this weird thing where it kind of like, you know, orbits around the sixth nerve nucleus and then shoots out this way. So you can imagine if you have a paramedian Pontine stroke, median meaning closer to the midline, you're going to hit these descending corticospinal tracts, and then you're also going to hit your sixth nerve nucleus, which moves the eyes left and right. So you're going to have a diplopia because one of your eyes, you won't be able to move it outwards when you look that way. The other eye will go that way, but this eye won't, and so you'll get double vision. So hemiparesis below the neck and double vision is one of your classic syndromes for a Pontine stroke, a paramedian Pontine stroke. Now you can have, I think on the next slide I have all the, no, I'll show you. You gotta have little lacunar strokes anywhere in the pons. Like, and look at all these different structures. I'm not gonna go through all the different syndromes, just so you know, depending on where you hit it, you can get different combinations of neurological deficits. But typically you'll get weakness or hemiparesis. And if you hit this blue fiber, that's your facial nerve, that's where you're gonna get facial weakness on the one side of your face, but weakness on the other side of the body, that cross motor weakness. And I haven't seen it much because look, you have to have a stroke that affects, here it's easy. You had a stroke in the sixth nerve, you're always going to hit the corticospinal tracts. But here, if you hit the facial nerve, it's got to be a big enough stroke to also hit some of the descending corticospinal tracts. And so here's an example of not a paramedian Pontine stroke, which I showed you. This is one of the lacunar or small deep Pontine strokes, which is often missed on initial read of a CAT scan. This is hard to sometimes discern from what we call beam hardening artifact. So I don't know if it's even that easy for you guys to see right there, but that's an example of a deep Pontine stroke, and it's from one of the small vessel penetrators. Here, for the record, is a list of all the Pontine stroke syndromes that I didn't want to inflict upon you. Just know that they exist, and it all depends on what part of the pons is affected. Okay, so in the last 10 minutes or so, I'm gonna hit the high points for the midbrain strokes. So the thing about the midbrain, I'll just shoot ahead here. There's an upper and a lower midbrain. So the upper midbrain, this is where the third nerve nucleus comes out. And then that's one of your, remember the third, the fourth, and the sixth cranial nerves are the three cranial nerves, the three sets that move your eyes. Right? So the sixth, we talked about it down in the pons. The third and the fourth live up in the midbrain. The third is in the upper midbrain. The fourth is in the lower midbrain. Okay. We're not going to really talk about the lower midbrain. We're going to focus on the upper midbrain. So where are those descending corticospinal tracts now? They're in what we call the crus cerebri, or the cerebral peduncles here. Okay, so we haven't indicated them like we did on the pons, but this is where all your descending corticospinal tracts are going. And you've got a couple other structures. Here, it would have been nice if it had been filled in. This is what we call the substantia nigra. It's in the midbrain. And, you know, the substantia nigra, what's that all about? Well, the substantia nigra is where all of the brain cells live that send out their supply lines to the basal ganglia to provide the basal ganglia with dopamine. Parkinson's disease is a disease of the substantia nigra. In Parkinson's disease, all of these cells that live in the midbrain die off. When about 90% of them are dead, then there's not enough supply of dopamine to the brainstem and you get Parkinson's disease. So, and the red nucleus is important in terms of coordination and so forth. So depending on where you hit the midbrain, you can have different syndromes. So here we've got Weber syndrome, Benedict syndrome, and Cloud syndrome. And I picked these because these are the ones that I hear people talking about all the time. There's a couple others, but I'm not going to go into them. So the Weber syndrome, all three of them, what they have in common is they all hit the third nerve nucleus. Why is that? Look at how easy it is to hit the third nerve nucleus. It actually starts over here, and it goes all the way through the midbrain and comes out in there. It's called the periaqueductal cistern. So you can have a stroke that catches this purple line, you know, the third nerve, in different parts of the midbrain, and you're going to have different related symptoms depending on where along you hit it or how big the stroke is. So Weber syndrome, the way I always remembered it when I was in medical school and residency is Weber and weakness, right? So Weber syndrome is the one with contralateral weakness, right? And so how do you get contralateral weakness? Well, because you're hitting the cerebral peduncle and you're also hitting this purple line. So you're going to have a third nerve palsy causing diplopia plus contralateral hemiparesis. Now you'll see in between the cerebral peduncle here and the third nerve here, we have the substantia nigra I told you about. So sometimes you can have, in addition to contralateral weakness, you could have a touch of Parkinson's-like rigidity. So it's not to be unexpected if you have somebody with a midbrain stroke, if you got the third nerve, I mean, therapists are going to have a heyday with this person because they've got so many issues. They've got diplopia, they've got weakness, they got a Parkinsonian aspect maybe to the weakness, right? So there's, that's Weber syndrome. Benedict syndrome, it's not so much the substantia nigra that is hit as it's the red nucleus. The red nucleus. And so that gives you, again, third nerve palsy, so diplopia from a third nerve palsy, but not with contralateral weakness. Remember, Weber's is for weakness. With contralateral hemiataxia and choreoathetosis. So that's Benedict syndrome. And I could never think of a good mnemonic for Benedict. Red Benedict, that's all I can think of. And then Cloud syndrome is ipsilateral third nerve palsy again. It shares third nerve palsy with the other ones, but contralateral ataxia. And it's because it hits some of the fibers going to the cerebellum. So I wanted to go through these three syndromes because they all have the third nerve palsy, common to them, and I hear them talked about a lot. And there's a map of the lower midbrain just for that. So that's pretty much most of what I wanted to cover. It's dense information, it's anatomy. I wanted to kind of go slowly and finish before people's brains got full. The last thing I want to talk about, it goes back to, let me see here if I can pull it up. The cerebellar strokes. Let me go back to the cerebellar strokes. Okay, here we go. So the last thing is cerebellar strokes. We often get very worried about them in the first 2 or 3 days because there's not a lot of space in the posterior fossa. In the posterior fossa, if you have a sizable enough stroke in a young enough person, why a young person? Because as we age, our brains do shrink. So there's less room for swelling if you're young. So a sizable cerebellar stroke in a young enough person can actually cause herniation of the brainstem. The swelling will hit the brainstem and you can die because your vital signs are mediated by the brainstem. So this is where, we say, okay, there's 2 ways we could have problems with a cerebellar stroke before they ever get to rehab. It's really a life-threatening stroke that we can do something about. And we monitor it. If someone has a decreased level of consciousness, we re-image them. And if we're seeing herniation, neurosurgery will often do a deep compressive craniectomy. They'll pull out the bone and permit the
gridlock in effect. ED gridlock in effect. ED gridlock in effect.
So for those of you listening to this taped, yes, I'm at the general, ED gridlock in effect. So basically you got to be very careful because it's a life-threatening situation that can sneak up on you if you're not prepared for the possibility. So it could be slow in coming, day 1, day 2, day 3, more and more swelling, and you see the person get drowsier and drowsier, and then you're like, oh, this is not going good. Or things can happen on a dime. How? Bleeding. So someone with a cerebellar infarct, we really don't want to anticoagulate them or promote any risk of bleeding because here we already see a little bit of hemorrhagic. If you blow a hematoma into the cerebellum, it's already swollen, you can herniate and die within hours, within an hour even. So that's why we have to be careful about that. So that's pretty much everything I was going to talk about, leaving plenty of time for questions. Again, being conscious, I didn't want to overwhelm people with too much. I hope that was a good balance of the anatomy and the anecdotes. I don't know. Okay, good. There's only so much anatomy people can absorb.
Thanks so much, Dr. Salas. I am just quickly looking at the chat, and there is one question there. I don't know if you saw it from Asunta. Is there prognostic indicators of these strokes you have presented where you would know are more likely to have better or worse recovery?
Okay, well, in terms of prognosis, I think all of these strokes are so different. The size of the stroke certainly matters, as always. You know, it's a good question, because with anterior circulation strokes, there's a lot of brain up in the anterior circulation. There's your frontal lobes, there's your temporal lobes, and you can have very big strokes, and so it's really hard to know what the impact's going to be, and people will be disabled and so on and so forth. If you have a big stroke in the brainstem, you'll die. Like it's not like the anterior circulation where you can have this big massive stroke and survive, and like a big stroke in the brainstem, you'll die. So the people that survive, the strokes are not that big, and they typically, because it's more all or nothing in general. And I'm really eager to hear what Dr. Feldman might say about this, but in general, I think the prognosis for posterior circulation stroke, because you're only dealing with the survivors with milder strokes anyway, is typically not that bad, if I'm making any sense there. So you're only really getting, there's no in between. With a brainstem stroke, there's no severe stroke that you're going to survive from. You'll either, it's you'll die, and it's not even, because it's actually, you can become brain dead very quickly from if you lose your brainstem function. So it's more of a dichotomy than the spread of prognosis we see with the other strokes. Does that answer the question, I hope, a little bit?
Jacinta, are you good?
Okay.
Good, thank you. Are there any other questions for Dr. Salas at this time? Feel free to enter them into the chat, or if you'd like, you could come off mute and you can actually ask Dr. Salas.
Well, go ahead.
Hi. Dr. Salas, thank you so much for an amazing presentation, a very, very difficult topic, and you made it really, really clear and easy to understand. So thank you for that. Question about degree of symptoms. So thinking specifically about the midbrain stroke syndromes you discussed, is there a degree of the symptoms that are similar across the different syndromes? So, looking at Benedict syndrome versus Cloud syndrome, would we see a difference in the degree of, let's say, ataxia? Does that matter in any way?
You definitely do see, and then I think Purvi was going to say something. You definitely do see a range, because these strokes, it's these descending fibers. If you hit them dead center, you're going to have more of a hemiplegia. If you hit them kind of just off center, it's going to be severe, but not as bad. Sometimes you just hit them just adjacent, and sometimes it's really more the swelling of the stroke that's causing the disruption. So there's a range for sure, everything from hemiplegia to mild hemiparesis. So, and you could have a small stroke, a bigger stroke, and the location really matters. Yeah. And then I think, did Purvi have something to say, or?
Yes. Yeah.
Okay.
How are you? Thank you so much.
Sure.
And it was a great explanation. It is very helpful. Now I have two questions. First one is that cerebellar stroke sometimes mimic with or mix with that BPPV if they have a history of BPPV. And first CT, second CT comes negative, and then we wait for MRI, and the MRI indicates that there's a tiny little stroke in the cerebellum area. And it is very hard to identify in that first 3 to 5 days until we have MRI done. So that's one question to differential diagnosis. And the second question, with any of the Pontine stroke or any other, the midbrain area, if there is a damage to the visual aspect, would you recommend to have further neural ophthalmology and a neuro-optometrist treatment or the therapy? Does that really help for the management?
Two very good questions. Okay, so first, in terms of the cerebellar stroke, the main thing is, dizziness and vertigo is an important component. And then the differentiation with BPPV. So here's the thing. If you have a pure cerebellar stroke, not affecting the medulla, the vertigo is really more of a medullary thing. So if you have a posterior circulation stroke with a strong vertigo component, probably the medulla is involved. But if it's just the cerebellum, vertigo isn't often a big sense, it's ataxia, right? So if you have a right cerebellar stroke, just a small right cerebellar stroke, the person is more ataxic in the ipsilateral limb than dizzy. But if you have a cerebellar stroke that also involves the medulla and you invoke the whole Wallenberg thing, then you have a vertigo component. Now, the thing about the vertigo from a stroke, so the part one of my answer to your question is that if it's pure cerebellar, you're probably not going to have too much of a vertigo. It's more the ataxia. And if you have a medullary component, because the artery goes to both structures, you're going to have a vertigo component. Now, here's the second answer to part of my answer to your first question. BPPV, I gave 3 P's. BPPV, it's really triggered by head movement. So if you have the person getting up and moving their head and that really makes the symptoms worse, it really suggests an inner ear pathology, not like a brainstem pathology. But if you have vertigo from like Wallenberg syndromes, you're kind of always vertigo. It's not like head movement doesn't matter. Like your vertigo lying down, you know, because you're damage to the actual in BPPV. It's a problem with the vestibular organ sending erroneous information to a healthy brainstem. So it's when you move your head a certain way, and then the inner ear is like giving you all this false information when your head is in this thing, and then you perceive dizziness because of the false input. But with a brainstem stroke, the actual brainstem, which is getting the information from the inner ear, is damaged. And so you're just dizzy all the time. So if you're examining somebody and really they're fine until they move their head and then they're dizzy, that's more inner ear. But if you're examining somebody and they're just constantly vertiginous, doesn't matter if they move their head or not, that's more likely from stroke. So that's the part 1 and part 2 answers to your first question. Is that okay so far?
Sure. Thank you.
So now in terms of your PONS question, it was about your vision. So in terms of the visual problem with the PONS, it's from diplopia. And certainly I see people, it's not an acuity problem. So if people cover one eye, they could see as well as they could before. If people cover the other eye, they could see as well as they could before. But with both eyes open, because your 6th nerve is affected, so if I have a stroke, a Pontine stroke in my right side, I don't have a problem looking that way. But if I try to look this way, it's my 6th nerve that moves my eye out over here, and it can't. So this right eye will stay midline, and my left eye will go over, and then I'll get double vision. So it's really the diplopia in one direction that people get. That's the visual problem with a Pontine stroke. It depends on where they're looking. And I've seen people referred to neuro-ophthalmology. I don't know. I mean, neuro-ophthalmology is extremely helpful in so many areas. I don't know how much they have to contribute in that thing, a 6th nerve palsy. They definitely, they could prognosticate maybe. I don't know of any specific management that they can do, but maybe I just don't know.
Okay, sure. Yeah, just because nowadays they have like a 3 months wait time. And I feel like that I do recommend all the visual issue patients to having proper thorough neuro-ophthalmology assessment, and if required, neuro-optometrist for any vision therapy. But then if there's no point, the patient who really need it should go see them first, right?
Yeah. For my part, I typically refer people to neuro-ophthalmology when we can't figure out what's wrong with them, and if it's more complex things. If it's a straight 6th nerve palsy, we almost will never refer to neuro-ophthalmology because there's no specific therapy for it that I know. It just will get better eventually, sooner rather than later. So maybe the best thing would be to get a neuro-ophthalmologist and ask them like which are the patients that you can actually offer more for, so we can kind of tailor our referral patterns to that.
Sounds good. I usually use the eye patch and then ask them to alternate both eyes, so then one eye doesn't get stronger than the other one, but it sounds good. Thank you so much.
Yeah, and I'm not an expert on the therapy part, so maybe Dr. Fellow will be able to kind of revisit that.
Okay, thank you.
Okay, now there's 2 other in the chat. Rehab in relation to eye issues. Do you think it's best to compensate early for deficits that impact function, or do you recommend wait and see? So I'm going to defer rehab questions to Dr. Fellow. We receive audio through the phone line. I want mute. Oh, I don't know. Okay. So, all right. anything else? I could talk a little bit about the PCA territory, or you could take a little break. Sometimes it's good to just take a 5-minute break between presenters.
Is there any other questions that we would like to ask?
Rhonda has a hand up.
Yeah. Jim, just wondering about great presentation. Locked-in syndrome, what do we see and what's affected with locked-in syndrome?
Okay, thanks for bringing that up. That's something that I could have talked about. I'm going to share the screen again just to talk about locked-in syndrome. So you see locked-in syndrome was in my list of Pontine syndromes in here, locked-in syndrome right here. Locked-in syndrome is a really horrible situation where people infarct the entire, both sides of the pons, but not completely. So if the entire pons were affected, then obviously they wouldn't have. But it's both sides of the pons, and it's a disconnection of your face and your body from your consciousness. And so locked-in syndrome, you're completely aware. You can blink because that's your 7th cranial nerve, and you do some eye movements, but you can't really speak or do anything else. And so it's important to identify locked-in syndrome, because it's got to be a pretty sizable stroke to result in locked-in syndrome. There's a very poor prognosis for recovery from it. So it's probably the worst thing that can happen in the brainstem. Yeah, but thanks for raising that. I think that it's interesting. I didn't speak about locked-in syndrome because I didn't know how much it would be for the rehab audience. But mind you, there's that really important documentary, the Diving Bell and the Butterfly. So people are aware that one of the editors of a French fashion magazine famously had a brainstem stroke that resulted in locked-in syndrome, and he pretty much dictated a whole book through his eye movements. He ultimately died. It's called The Diving Bell and the Butterfly. And they actually filmed a movie based on the book. And I remember in the movie, he interacts with therapists a lot, actually. So there's a lot of therapy to keep to avoid muscle breakdown, to avoid ulcers and stuff like that, pressure sores. So I don't know how often do people care for locked-in syndrome. We also need to be in an ICU, I think, right? So that's where I don't think that they typically, I don't know that anyone here has really cared for patients with locked-in. Maybe I'm wrong. Has anyone cared for personally a patient with locked-in syndrome? They usually require way more intensive care. Yeah, so important to know about, but I didn't dive into it a long time ago, Amy. Okay. Oh, and Maggie's treated. Okay. Yeah. So yeah, definitely important to be familiar with it.
Dr. Salas, again, just from Susan, she has said with lateral medullary syndrome strokes, the vertigo, nausea, vomiting can be extremely debilitating and prevent the patient's ability to participate either in sessions or in assessment. Do you have any pearls on treatment? Is it a wait and see?
So Susan's also encountered the really severe nausea, vomiting. We typically just use antiemetics. We've struggled with that, definitely. It doesn't linger forever, so it definitely improves over time. So I think certainly on the one hand, if you want to do therapy earlier, you might want to give antiemetics. Different combinations work better than others for different patients. Usually it's, let's try what we can today. You can't do it, we'll try again tomorrow or the next day. And eventually, from my experience, it doesn't last forever. So I don't really have any specific pearls because it's as you say, it's extremely like a low threshold to just spontaneously vomit, like with no warning. So hopefully Susan hasn't had the same experience that I've had, with probably as a therapist has. So.
Susan indicates she's tried a danzatron regularly with dosing for a few days. So sometimes I think she's had.
Okay.
Very good.
Yeah, so as a baseline, yeah, I agree that giving something on a regular basis probably makes sense. You wouldn't, I totally agree with her. You wouldn't want to wait for the vomiting to actually, you should probably be treating it because it's present all the time. So I think a daily antiemetic and danzatron is a good idea.
Well, thank you very much, Dr. Salas. We've just got a couple of minutes to 1 o'clock, so maybe we'll take the opportunity to transition. Your presentation has been great. Doing the anatomy reviews was very helpful for me, brought it all right back.
Yeah.
So I'm sure for me and for many of us who participated. So we really want to thank you for sharing your expertise and your experience with us and making it very clinically relevant for us. So thank you very much.
Thanks very much. You're welcome, and enjoy the rest of the session, everyone. Dr. Fellio is going to have a fantastic presentation on it. Okay. All right. Thanks everybody. Bye-bye.
Thank you. Very good. So what I would like to do now is welcome Dr. Florin Fellio, who will be presenting next. And Dr. Fellio is our assistant clinical professor with the Department of Physical Medicine and Rehab at McMaster University. And he also serves currently as a staff physiatrist at the Regional Rehab Center at Hamilton Health Sciences, where he works on the inpatient stroke neuro program. He also supports the comprehensive spasticity management clinic in the outpatient area, as well as doing musculoskeletal and EMG. Dr. Fellio also is a consultant physiatrist to St. Joe's Healthcare in Hamilton. He also supports Hotel du Shaver, where he supports the outpatient Parkinson's rehab program. And he's also a consulting physiatrist to Cambridge Memorial Hospital for their inpatient general rehab. So today, Dr. Fellio is going to present on the rehab approach to posterior circulation stroke deficits. So I welcome you, Dr. Fellio.
Thank you very much for having me. Can you guys hear me okay?
Yes, you're coming across well for me. Thank you.
Okay. I cannot see myself, but it appears that there's a camera here. So I hope, can you guys see me as well?
Yes, we can see you as well.
Okay. So thank you for being here. Thank you for inviting me. I will present the rehab approach to posterior circulation stroke deficits. And a lot of slides, I have, I think 60 something slides, because, and I didn't know what Dr. Salas would put up. I had an idea. And because of that, I wanted to include some slides as well about anatomy, of posterior circulation stroke and brainstem. I'm not going to go over them. I'll just skim through them. They will be there for your reference as the time goes by. I will skip towards the end of the presentation. I'll start talking about rehabilitation. But I have a few slides that I'll probably go over just as a refresher from Dr. Salas's talk. So let me see, I didn't do anything. Okay, so this is my disclosure, the objectives, the general aspect of posterior circulation. As I said, I will be very brief on that. Deficits, I'll talk about the deficits from posterior circulation and approaches. There are a few questions that the group had for Dr. Salas, and I'll try to give you guys my 2 cents about what I think or how we do things and what's the evidence behind it, or at least what's the rationale behind a lot of things that we do with people that have had strokes in the posterior circulation. Okay, hold on. Okay, so this is the outline of the talk. As I said, I'm going to skim. I'm going to skip a lot of anatomy slides. I will talk about prognostic factors. So this ties into which people will do better, which people will not do better. And I'll make some comments when I get to that slide. Talk about some theories of rehabilitation and some therapies. I wasn't sure who's going to be in the audience, so I geared towards a rehabilitation team, if you may, including the occupational therapist, physiotherapist. I have a couple of my residents, most likely online as well, that are more familiar with medications. So these are important references for everybody to know if you want to go more into stroke rehabilitation. I would say the EBRSR is probably one of the most important ones that you've seen, and it has probably the most updated references in that respect. Okay, so you know about the stroke, hemorrhagic or ischemic stroke. This is an interesting picture that I thought we'll just put together the anterior circulation and posterior circulation so that you have a better understanding about what is going on with that. So this is a right side picture of a neck and face, if you may. This is the brachial, you see my mouse, I believe. So this is the brachiocephalic trunk on the right side that splits into subclavian artery and common carotid artery. Then common carotid artery here on the front forms external carotid artery that goes to the face and internal carotid artery. And then internal carotid artery will go into MCA, into ACA. Now you don't see the ACA here, but what you see is the PCOM. This is posterior communicans artery. This is the PCOM. Now I'm going to go down again on this artery. So from subclavian artery here, you get one subclavian on the right and then another subclavian on the left that comes straight from aortic arch. So both subclavians will provide one vertebral artery, one on each side, as you can see this on the black arrow, and that goes up through the transverse foramina of the cervical vertebrae, goes up, it curls in, it goes into the brain, and you can see those two. One is cut over here, the one on the left side. The one on the right side is not cut. Both of them come and they get together in between the medulla and pons, and then they form the basilar artery. Probably these two here that you see are the superior cerebellar arteries, and it ends with two posterior cerebral arteries from which the posterior communicans makes the connection between posterior circulation and anterior circulation. So it just tells you that basically there is a circle here between anterior and posterior circulation. I thought that was important in understanding. Okay, I'm not going to go through this. This is the brainstem that Dr. Salas talked about. My point here is that the posterior circulation serves the brainstem as well as the occipital lobe and inferior part of the temporal lobe and the cerebellum. So it's not only the brainstem, as Dr. Salas mentioned, it is the occipital lobe, the cerebellum, as well as the inferior part of the temporal lobe. Dr. Salas had this picture as well about the blood vessels for the cerebellum. As I said, I'll just skim through it. These are different pictures already talked about. The two systems here, the vertebrobasilar system. So that if you may, there are two systems that basically give you different impairments. The vertebrobasilar system, which is this one over here, with the two verts, basilar, and two PCAs here. And the PCA basically has, as it goes, it wraps around, goes at the back, goes to the occipital cortex, and it has a branch straight into the thalamus as well. So the vertebrobasilar system has the three arteries that you see, and the posterior cerebral artery goes into the thalamus, occipital, and inferior temporal. So you're going to get different deficits depending where exactly the stroke is within the posterior circulation. This is a slide just to let you know that, in general, people think about anterior circulation and they think about, these are sensory tracts, so corticospinal tract on this side, lateral spinal thalamic tract on this side, and proprioception tract on this side. As you can see, if you do hit the primary sensory cortex on the parietal lobe, you're going to end up with a sensory phenomenon, a sensory dysfunction. But also, all these fibers go through the brainstem. So if you get a stroke in the brainstem, which is served by the posterior circulation, you may end up with sensory deficits as well. And this is another slide about the corticospinal tract. Again, that has a primary motor neuron on the motor cortex, on the precentral gyrus in the frontal lobe. And usually we know about it in red, but I just found this picture online in blue. The idea is it comes from the primary motor cortex, it goes down, travels through the brainstem, it decussates into medulla, so it goes to the other side. If you have a stroke in the brainstem, you end up with weakness as well. So again, you can end up with weakness and sensory deficits with both an anterior circulation stroke as well as a posterior circulation stroke. Just some tips, if you may, and Dr. Salas already talked about this. So if you get the cerebellum affected, the side that you get the cerebellum affected, you're gonna get the ataxia. So cerebellum leads to ipsilateral ataxia. This is the rule of thumb, if you may. Cranial nerves, you will get ipsilateral deficits. And you know the order 1, 2, 3, 4 in the midbrain, and then in the pons 5, 6, 7, 8, and in the medulla 9, 10, 11, 12. So any ipsilateral cranial nerve deficit means that there is something happening in the same part of the brainstem. Okay. The cross signs is, again, it's an important thing. So if you get the cross signs means weakness or sensory loss on the face and weakness or sensory loss on the limbs contralaterally. So ipsilateral face, contralateral body. The moment you see that, it is probably a brainstem phenomenon, whether it's a stroke or a tumor or whatever it may be. But the cross signs is classic for the vertebrobasilar system. And also Dr. Salas mentioned this as well. All these cortical deficits that you may have seen in your patients, aphasia with a caveat, and I'll talk about it, apraxia, neglect, all those are absent in people that have a vertebrobasal stroke because it does not affect parietal cortex in particular, where you would see a lot of these phenomenons and aphasia, either frontal or temporal, but it doesn't affect the cortex itself. So that, again, that if you have neglect in a patient, it's likely an anterior circulation. It's unlikely to be a vertebrobasilar system problem. I'm not going to go over this. You have it there on the slides. Dr. Salas talked about it. The same deficits that you're going to have, and I'll talk about how we address those in rehab per se. This is lateral medulla syndrome, medial medullary syndrome on the next slide. The lateral, sensory on the face, contralateral on the body, no weakness. Because the corticospinal tract is medially onto the medulla. Whereas a medial medullary syndrome, you're going to get contralateral weakness on the body and ipsy tongue. Okay, I'll just browse through them. I just want to mention as well that these syndromes, the description of them, I got them from EBRSR. I've seen other sources that list slightly different impairments within different syndromes. What I usually tell my residents is basically just study EBRSR, at least for our final exam, because most likely you're going to use that as a reference. You know, instead of remembering whatever reference you got about, you know, do you have weakness on that side? Do you have rigidity on that side? So it's easier, just remember EBRSR. So I'm going to go, this was the medial pons, and I'm going to go into the brain, midbrain Weber syndrome that Dr. Salas talked about it, and Benedict syndrome, which I call that a Weber plus, if you may. And you can see the structures that are affected in Benedict syndrome as well. One slide about locked-in syndrome. The idea with this is indeed the injuries on the pons, you're going to hit the corticospinal tract and corticobulbar. Basically, the only thing people can do is they can use the eyes and blinking to communicate, and the consciousness is intact. And this is again because you're damaging all the motor output to the body. Moving on to the second part of posterior circulation, which is basically posterior cerebral arteries. The posterior cerebral arteries will go to the occipital lobe, and these are the impairments that happen if the occipital lobe is being affected. You will get homonymous anapsia, so you're not going to see on the opposite side of whether the occipital lobe was hit. Visual agnosia, you're not able to perceive or recognize objects or whatnot. But again, the idea is you're not able to recognize. So those are cortical phenomenon because you're going to hit the cortex of the occipital lobe. That is why you're going to see that here. Alexia, you cannot read. aphasia. So you can hit on with the left PCA. People can end up having transcortical sensory aphasia, and I have a couple of slides about that. Visual hallucinations, color discrimination issues as well. Impaired memory, if you go into the lower part of the lobar of the temporal lobe, and the thalamus is mostly known as a third order neuron relay for the sensation. People may end up with contralateral sensory loss, but they can end up with weakness. It has there's a nice review article about thalamic strokes, and it has a wide range of deficits. These are common. So from all the prior slides, I just made up a slide of common posterior circulation deficits, so that would be easier for us to follow with respect to how we rehabilitate them. Basically, it's a summary of the prior slides, but I wanted you to have it like this here. It is very important when us as a physiatrist, we talk about impairments, disability, and handicap. So an impairment is basically a loss of abnormality of the body structure or psychological function. For stroke mainly, and a lot of stroke populations, they think of weakness. A lot of people think of weakness because weakness will not allow you to sit at the edge of the bed, stand up, transfer, walk around. So that weakness in particular is considered an impairment, a physical impairment. Now that weakness may or may translate into an inability to perform a functional task. So you may have some weakness, but you may be able to sit, to stand, to transfer, to walk using a cane or a walker. So you can still perform a functional task. Or some people, because of the weakness, are not able to perform a functional task. So we wanna see, well, if you have a weakness or impairment, how is this weakness translated into your ability to perform a functional task? And more so, how is this weakness or your inability to perform a functional task such as ambulation affecting your ability to participate in the environment? Are you able to go to the mall? Are you able to go to doctor's office? Are you able to play? This is the framework that we tend to think about when we're looking at deficits in general, and for this session today, stroke impairments in particular. Now, stroke recovery. So after an area was hit by a stroke, either ischemic or hemorrhagic stroke, there are two types of recovery that can happen. Both of them happen at the same time. And basically they start day one of the stroke. So we can think in these two frames, there is a significant overlap between the two of them. We can think about a neurological recovery. Basically, we're trying to get the swelling out. We're trying to improve the strength. We're trying to improve the sensory deficits. And this will translate into a functional recovery. So we're trying to improve the function of the person that has whatever weakness they have at one particular moment in time. And these two are both influenced by rehabilitation. Remember, the swelling is there for 6 to 8 weeks, probably up to 2 weeks, then the swelling comes down. So the neurological recovery, once the swelling is not there, then you'll start seeing the majority of the recovery happening within the first 1, 2, 3 months or so. Then it doesn't plateau completely, but the pace of the recovery will be slower than it used to be within the first 1 to 2 to 3 months or so. The majority of those neurological recovery impairments will happen within the first 6 months, and then slowly up to 1 year. Now, the same thing for functional recovery, but the functional recovery, obviously, it is influenced by rehabilitation, by motivation, by supports, and it can continue after you've recovered your neurons, but you try to make more connections in order to improve your function. So it can continue after the neurological recovery has settled in. How do we recover earlier in an acute stroke, either from a bleed or from an ischemic stroke? The edema goes down. So the swelling disrupts the neurons. Some of them will die, some of them will not die. And this is the edema here on the screen that you can see. The neurons that will not die are in a stunned situation, if you may. They're not dead. And some of them will probably die, and this is closer to the core of the original death cell area. And some of them will survive as the time goes by. When the edema will resorb, as you can see in the screen, when the edema will resorb, then you're going to see a lot of neuronal activity that translates into improvement in the strength as well as function. So this is one of the most important steps in stroke recovery. And that is why, some people may end up in the ICU, and they stay in the ICU up to 2 months or 3 months because of medical comorbidities, and they come out of the ICU. I would say that unfortunately for that population, when we say about the first 2 to 3 months or so, the majority of the recovery happens, they've had their neuronal recovery, but they haven't had a chance to work to improve their functioning because they're basically in the ICU. So it is very important to understand that no matter what keeps people outside of a rehabilitation unit, if you may, the neurological recovery will follow its course. And that is why we tend to, we want to get people as fast as we can to our rehabilitation unit. But we are mindful that some people basically stay in the ICU for 2 months, and they missed that opportunity to have a functional recovery on top of whatever they're getting, their neurological recovery from the edema resolution. These are other ways of improving neurological recovery. Toxic factor elimination, diaskesis. This is an interesting term. Basically, what it means is that if one area of the brain is damaged physically from a stroke, there are some functional connections between that area and another area of the brain. So basically, both of them will shut down. But the second area was not physically damaged by the stroke, but rather it's shut down due to some functional connectivity to the area that was damaged. So we want to see this diaskesis resolving so that that connection will start to work again. And that is why you may see sometimes you may see some people that may have some weakness or incoordination or whatever it may be, that may not be fully explained by an anatomical location of the stroke. And then we need to say, you know what, maybe it was diaskesis that kicked in due to a functional connection between the area that died and the area that has not been affected by the stroke from the blood flow point of view, but has been affected from the functional connectivity point of view. Neuroplasticity is another big term, is probably the biggest and most important term in stroke rehabilitation. The idea is the central nervous system will reorganize and remodel after an injury. And these are ways of trying to reorganize after an injury, whether stroke or brain injury. It is influenced by rehabilitation. You have to understand that usually those neuroplasticity phenomenon can happen at the cortical level where you have the body of the neurons, because we know that a corticospinal tract, once injured, such as in people with spinal cord injury, it doesn't regrow. It doesn't make any new synapse with anything else. It just sits there. So all that reorganization will probably happen at the cortical level where the body of the neurons are. And that is important to remember. And I'll probably touch base with brainstem strokes. And now you probably appreciate now that in a brainstem stroke, for example, medial medullary syndrome that has weakness that hit the corticospinal tract, there is no dendritic sprouting anymore. These are just corticospinal tracts. Some of them will die. Some of them will get better due to swelling resolution, but there's no sprouting there. So a lot of times the rehabilitation prognostic factors are basically being given by a clinical presentation.
Sorry, cannot hear you.
Can you guys hear me? I haven't changed anything.
I can hear you fine.
If there's anything else you want me to do, I'll do it, but you need to tell me. I haven't changed anything.
We can hear you fine.
Okay.
So I'm not sure what's happening on Purvi's end. Sorry.
Can I continue
Okay,
then?
now good. Sorry.
Okay, okay, good. Okay. So let me just share it again. The functional recovery that we talked about is you have an impairment, you have weakness, and I want to know how much you can perform with the amount of weakness that you have. So this is important. This and everybody knows in the stroke rehabilitation field that there are people that have the same type of weakness, and some of them can do more than the others because they recovered functionally better than the others. So these are ways of via the functional recovery recovers diastasis resolution, and we think there is evidence that amphetamines may help with that, where you basically shut down that inhibition to other areas of the brain. Around the rim of the dead area in the brain, there's going to be some vicarious, is called reorganization, which means some healthy cells will take over a function of the damaged neurons, and reorganization in the damaged hemisphere as well of the activation in the motor cortex at SMA. So basically something happens, and that happening leads to an improvement in function. And these are the mechanisms that we think leads to those improvement in functioning. It takes months. It goes past the neurological recovery. Simplistically, the swelling goes down, neurological recovery is done. That's simplistically, okay? But the functional recovery will continue to happen because you continue to make those connections in the brain, take over in the brain, diastasis resolution, and with the same amount of weakness, you will continue to improve your functioning. And there are predictors about functional recovery. Two predictors have been found to be reliable in the literature. The more severe the stroke on the initial presentation, the least likely that person will get a good functional recovery. Because the idea again is that you don't have that reserve in the brain to try to take over all those neurons in the brain to try to take over and improve your functioning. And the other one is age. And age probably relates to the reserve as well. You have a lot of reserve. I think I read some reports about, past the age of 18, we start losing neurons. It is what it is. And the younger you are, the more likely to have a better reserve that will act in your favor. You can make new connections, you can take over some connections, and that will help you recover better. So stroke severity and age are two significant prognostic factors for recovery. The earlier we get people into a rehabilitation unit, the better. The more we work with them, the better with respect to intensity of time. And I have a slide about specificity as well. It doesn't apply to everybody. There are some studies that show that if you start rehabilitation too early after stroke, within the first 24 to 48 hours, especially for strokes that have significant physical impairments, you may actually do more damage. And probably the idea is that the healthy neurons that are not involved in the stroke are not able to take over, and they may work in overdrive, and they may not be able to basically form new connections, if you may. This is at least one idea why that is happening. But in the majority of the cases, this is what it applies in terms of stroke rehabilitation. I wanted to have a slide about Brunstam. So Brunstam said that your recovery, if you start on a flaccidity, will go through all these seven stages. But you can start, when you see somebody, you can start at 3, you can start at 4. There are some people that start at 6. They only have just issues with ataxia and complex movement, coordination is affected. You don't have to start on 1. But if you do start on 1, the idea is that you will progress through these stages. Whether you reach 7 or not, we do not know. We tend to say that you tend not to skip any phases, and you can always stop at any stage in the recovery. But the idea is this is a continuum of stages. For my residents, they always like this question on whatever exam, because it's easy to remember. A couple of slides about rehabilitation approaches. In the 90s, there was that theory that if you avoid the synergy positions on the upper and lower extremities, you may do better compared to if you don't avoid those positions. And studies have shown that basically whether you avoid or not, it doesn't matter, the recovery is the same, but people that avoid those synergy positions tend to stay longer on a rehabilitation unit. So we're not using that anymore. We're still using this PNF. So some people are using it, and I've seen it in some facilities as well. You try to use diagonal and spiral movements, which basically give you some proprioception stimulation or facilitation, if you may. So that was about 5 years or so after bull bath. Then another rehab theory came on, which is basically, what about if we try to stimulate physically and facilitate by tapping or massage or other means of physical or electrical stimulation? Would that improve would that speed up the recovery? And it is being used currently on multiple units. But Karen Shepherd in the 80s came with this idea that if you have weakness in the right upper extremity and you want to open a door, just open the door. Just try to open the door 100 times per day. And that is basically a task-specific training. If you cannot walk, just walk. If you cannot feed yourself, just try to feed yourself, perform a specific training through problem solving. And the idea is that with the same amount of weakness, you may be able to improve your function so that you're getting better at those tasks that you are practicing. And this is probably the main approach in a lot of rehabilitation units nowadays. And there, some of the therapists are using the other approaches as well, keeping in mind that this motor relearning, Karen Shepherd, is most likely the main one being used. We talked about the severity of stroke. There are a few prognostic factors for stroke recovery of the upper extremity. They're good and bad prognostic factors. Now, remember, the idea is that they tend to apply to everybody that had a stroke. Those studies that looked at these prognostic for recovery did not include only posterior circulation strokes. So they're all strokes with weakness on the arm. They track them down. And what they notice is that if you have finger extension at day 3 or shoulder abduction at day 3, that is considered that you would have a good functional use of the arm at 6 months. So, you know, day 3, usually they may not be on my unit. They tend to come day 4, day 5, day 6, but I would use the same thing. I would say day 3 has passed. If they have that when they come to my unit, then I'm comfortable that they have more chances to have some dexterity and using their arm functionally at 6 months. If, on the other hand, if they have complete paralysis when the stroke happened, so dense hemiplegia or prolonged flaccidity, remember the Bronston stages, stage 1 was flaccidity. If they stay in that stage 1 and they're not progressing through stage 2 to stage 3, or if they have a lot of shoulder spasticity or no grasp by 4 weeks, it is unlikely that they would recover that upper extremity functionally at 6 months. And those people usually are within a rehab facility at 1 month. So those predictions can be made. And they have to be made gentle. We have to understand that, you know, we are doctors and we want to keep the hopes for the patients. But on the other hand, we have to tell them the evidence, because some people, you know, are being told that, you know what, yeah, continue rehab, do physio for 10 years. And at the end of the 10 year, you're going to use the hand the way you had it before the stroke, which is not going to happen. but I've seen these statements being told to the patients, and that's not right. A little bit of mobility. I would say that a lot of people, when they come to through an inpatient unit, they walk with a gait aid when they're discharged from the hospital. If you sit okay 3 days, and if you have some voluntary movements, 6 months you walk with or without the gait aid, 98% of the people. So that is reassuring. And the people that don't have good sitting balance, they're not able to activate anything, those are the people that it is unlikely they would regain an independent gait with or without a gait aid. So let me see the time. Okay, we're good. I'm going to talk about those bolded items, how we approach them. Now, the sensory tends not to be a significant impairment that is related to us by the patients. If you have numbness or a little bit of tingling, that does not affect your ability of walking around or feeding yourself or dressing yourself. So I'm going to focus on those bolded things, what we do on a rehabilitation unit. So for the weakness, there are a few medications that I have tried, small studies, small sample size, fluoxetine, levodopa, amphetamines. I'm going to skip over. You guys have the slides. You can learn about it. The idea is you try to stimulate any connection whatsoever by bringing some of those medications to the brain. One of them was fluoxetine. This study came on 2011, FLAME study. They had people on fluoxetine 20 milligrams daily versus placebo. It was a randomized controlled trial, very well conducted trial for 3 months. And this is 3 months, so this is time from stroke. They're enrolled within 10 days from the stroke. And they use the Fulmire scale. This is a weird scale. It has 6 pages. It has a motor component. It has an upper extremity, lower extremity. It is a heavily impairment type scale. So basically it tells you how much weakness you have and how much you're able to do active movements and how much passive movement you have available of the paretic limb. So it's a heavily impairment scale, okay? So you can see the fluoxetine group with this small triangle, 90 days is way above the placebo group. So the idea is they showed a better recovery in people that have taken fluoxetine versus placebo. Sorry, this should have been 90 days, my bad. But if you move your wrist from 20 degrees, you start in neutral and you move it from 20 degrees, from 0 neutral to 20 degrees extension versus from 0 to 30 degrees wrist extension, that will translate in an improvement in Fulmire. But would that small range that is statistically significant on a Fulmire give you any benefit in terms of functioning? Are you able to dress better? Are you able to eat better? Are you able to walk better? So the question was answered in the FOCUS trial. The FOCUS trial came in 2019, so a couple of years ago. They had 3,000 or so patients enrolled within 5 days from stroke. And they said, look, if fluoxetine helps, why not prolong the amount of time we give that fluoxetine? We know the majority of the stroke will recover within the first 3 months, but there is still significant recovery between 3 and 6 months. So might as well just give them for 6 months versus placebo. And they use this scale. They use modified Rankin scale at 6 months. This is the modified Rankin scale. So basically at 6 months, they looked at the 2 groups and they wanted to see whether there was a difference in the 2 groups in respect to where people fall within this modified Rankin scale. So modified Rankin scale 1 means you had a stroke, but you had no symptoms from it. You recovered completely. 2, you had a stroke and now you're dead. So this is the scale. So they traced the people for 6 months and they wanted to know whether there was a difference between the 2 groups at 6 months with respect to disability. This is a disability scale. So this is the result of the study. Basically, these are the 2 groups that you can see. This is modified Rankin scale 0, 1, 2, 3, 4, 6 here at the end. there's no difference between the two groups. So placebo group had the same amount of people in all seven slots of the scale as they were in the fluoxetine group. So the conclusion of the trial was basically, while we didn't look at an impairment, which was weakness or range of motion, we looked at, can you do better? Can you walk better? Are you still bedridden at 6 months? The answer is, it didn't change anything. There is no improvement in function. There is no improvement in disability. Both groups did the same. Moreover, they noticed that there was a statistical significant increase in bone fractures on the fluoxetine group. Unknown cause for that, but it was noted in the trial. So the takeoff is fluoxetine doesn't change anything, and I can tell you that I've used fluoxetine based on the FLAME trial for about 6-7 months or 6-7 years or so until the FOCUS trial came on. So it doesn't change anything. May lead to bone fractures, and yes, the trial, the study group that had fluoxetine had the lower incidence of depression, but this was not the primary endpoint of the trial. And it's intuitive, of course, because there are a lot of studies that show that if you put people on SSRIs, you will get decreased incidence of depression. So that didn't actually change the practice. We knew about it from before. So we're not using fluoxetine anymore. But there are other trials as well. Levodopa, for example, this is a 2001 study, 53 ischemic stroke. So again, all those 2001, 1995, 1998 trials, they had just under 100 people. And they put people on 3 weeks levocarb plus physio versus physio. And you can see here on the scale, they measured at 6 weeks. They had people 3 with levocarb and 3 physio, the other one physio only. This is the motor function on the Rivermaid, and this is the arm function on the Rivermaid. So they noticed that open circles here is the levocarb here versus placebo. So people on the levocarb did better. Now, I am using levocarb in some people. The thing with levocarb, it was really difficult to, levocarb can give you hallucinations. And you have to be, if people have delirium, that's a problem. Elderly people, you throw levodopa at them, they will start seeing things on the walls. And with that in mind, then we start doing blood work and everything else for delirium. So it's really difficult to use it in a lot of population. And usually people over the age of 70 tend to form probably the bulk of what we see in rehab. But it is an option that I use it from time to time. Ritalin, this is a study that I tend to use a lot for my patients. 21 patients only. It was a 1998 by grade. They had them on Ritalin 15 milligrams, and it was at 8 o'clock in the morning at noon versus placebo for 3 weeks. There was no graph on that study. I have the PDF version. Basically, they just talk about it and they show some p-values. They did better on the study group. Better motor recovery, better ADL function, and that's depression. And as a matter of fact, this study is being cited in EBRSR, and with the results of the study support using Ritalin for people that have depression, because it tends to kick in and perk them up within 3 days or so of using the medication. So just a caveat for people that are identified to have depression within a rehabilitation unit, what we do here is we tend to put them on Ritalin and an SSRI at the same time, and we take the Ritalin off at 1 month when the SSRI medication has kicked in already. But the primary point was not depression; it was motor recovery. Ataxia was another impairment from a posterior circulation stroke. Whatever the task is, just do it, right? And you're going to see visual feedback will help you as well, because it will help your arm, will help you to see where to stop it. So proprioception, feedback, cerebellar will will help stop those movements from becoming ballistic, if you may, but visual feedback will help. Remember, they have swelling, the swelling will go down. So again, this is just simplistically put, the swelling will go down, they tend to get better. Ataxia is one of the impairments that takes a long time to get better. And this is because fine movements, if you may, are complex movements, and people tend to get better with gross movements first, then fine movements. So it takes a longer time. Usually people that have ataxia as their impairment, they need a longer rehabilitation time than people that don't have ataxia. And weights will help as well. And you may have seen the therapist, and for those of you that are using this, they put weights around distal upper extremity or lower extremity. They weight the gait aids as well, usually the walker. So that will help because it helps the body to feel a heavier limb, and that will not move it ballistically on a dysmetria task, if you may. So this is what we do for ataxia. Transcortical sensory aphasia, you can get it with a left PCA ischemic stroke. Difference between transcortical sensory and Wernicke is that people with transcortical sensory can repeat. So comprehension is affected, but for whatever reason, they can repeat. Aphasia is an impairment that is detrimental for recovery. People, if you have transcortical sensory or Wernicke's aphasia, they need to be supervised in the community. They're fine, they walk fine, they don't have any weakness, but they need to be supervised in the community because their comprehension is significantly affected. Our speech language pathologists are using a bunch of treatments to try to improve the aphasia that you have here. There are some medications that have been used in randomized controlled trial, and they're listed in EBRSR as well for people that are interested. For acute aphasia, which basically they define it within a month from the stroke date. Piracetam, there is one trial, and it's an European trial, is not available in Canada. We're not using it. Sorry, it's a level 1 trial, is not available in Canada. I had a conversation with one of my residents, whether they say, EBRSR, you really have to read the studies and look in those tables. Not to, I would say that the conclusions are somewhat confusing for the reader. Just read the study, just read the table. They will say there are 10 studies identified that met the criteria, and then they have a table and they have the studies, and at the end of that table, they'll tell you whether it's a positive trial on the control group, on the medication group. And at the end, the statement is somewhat confusing, may help, may not help, we do not know, something like that. So dexedrine, I used it a lot for acute aphasia. Again, all those studies are not necessarily for transcortical sensory aphasia. They're for a bunch of aphasias. Subacute levocarb, I use that as well. And again, remember, hallucinations is one, hallucinations are one side effect. And acetylcholinesterase inhibitors and NMDA receptor agonists, memantine, are being used as well. And I use them in that population. I tend not to see chronic aphasia. I tend to see it in the acute, and then they just go out in the community. Nausea, we talked about nausea. The nucleus is affected, as Dr. Salas mentioned. I just have a few more minutes. The nucleus is affected. So people with BPPV, you send a signal every time you move, that calcium otoliths or whatever starts moving. So they tend to get that nausea when the head moves. But these people with a vestibular nucleus in the lateral medulla, it's the computer. The computer is affected all the time. They get dizziness all the time. They will complain of spinning most of the time. People will have other descriptions as well. It's not one medication. You wait for the swelling to go down. And in the majority of the people, 6 to 8 weeks, they have no dizziness. Some of them will have residual dizziness. We're using the medications to try to knock off basically the vestibular nucleus stimulation, if you may, or input. And those medications, Gravol, we use it for nausea. It has a lot of anticholinergic side effects. So people will start having urinary retention all of a sudden, or get drowsy, or have hallucinations. We're using ondansetron as well. Metoclopramide will stimulate the gastrointestinal tract. So basically, you're trying to stimulate the food to go down the tracts so that you don't vomit it out. CERC is something that we've used. It's used for BPPV. Not one of those is a great choice, I can tell you that. We tend to use it if we see that people are not able to participate in rehab, and we choose one, run it through a few days, nothing happens, maximize the dose, nothing happens, side effects, switch it to another one. Dysphagia, you'll have it on slides. I'm going to flip through it because I don't have that much time. The management for that, 3 areas: low risk feeding strategies, exercises, or compensatory techniques. So our speech language pathologists use that as well. These are the low risk feeding strategies. These are exercises that you can do in order to improve the dysphagia. And these are compensatory strategies. So you try to either modify the food, consistency, presentation, you try to turn the head to the damaged side so that you choke or constrict the side that is weak, or tilt to the normal side to make it as a pipe, if you may. And these are other compensatory strategies. Hiccups, another impairment. Cerebellum tends not to give that. Occipital lobe tends not to give that. A lot of medications have been trialed. N of 1 studies, some poorly done randomized controlled trials. We're trying a bunch of them, one after the other. Baclofen seems to have, and it's a medication that may give you drowsiness and dizziness, but not to this dose. So I tend to use baclofen a lot in people that have hiccups. All the others have been tried and they're listed in some studies, but not significant randomized controlled trials with excellent evidence. Double vision, cranial nerves are affected. As Dr. Salas mentioned, one eye is just, it's weaker, so it doesn't align the image on the occipital cortex. That's exactly what it is. It doesn't align it. Therefore, what you tend to do is you wait. You wait up to 3 months from that swelling to go down. And in the majority of the cases, that happens and people will not have diplopia. If you have past the 3 months, what they tend to do is, as you can see here, they do prism goggles. So if this eye is, you're going to use over the lazy eye or the lazier eye, if you may. So if this eye cannot turn to the right, if they have a right C6 a nucleus stroke, you're going to use the prism to basically switch the visual field more to the right. So they look for the prism, but the visual field will be switched to the right. So, or the other way around is basically the same principle. So you're using the prism to try to align that image onto an eye that didn't move far to the side. You're just using the prisms. So that will align, that may help aligning on the back of the visual cortex. So they use this, you cover one eye. The idea is to try to patch it because one eye will get lazier. So patch one, 1, 2, 3 days, 4 days, patch the other one, 1, 2, 3 days, 4 days. They don't have a problem with one eye in particular. They have a problem if they see with both of them. So you patch one so that they don't get double vision. Homonymous synopsia, just this is the test and this is the way you see it. This is on the left side. This is the way it's being documented. It's on the left side. Now this guy here, so we tell them, they figure that out almost immediately, that they cannot see on the right side. So they need to turn the head to the right. So a lot of people will figure that out. You don't need to say that to them. Usually elderly people with some mild cognitive impairment, possible vascular dementia, with not a lot of reserve, they cannot figure that out. And even if you tell them, they still cannot figure that out. So they won't be able to see on the homonymous synopsia side. So a lot of times what they do, and again, you don't do that prior to 3 months. You want the swelling to come down, and what you do is you put a prism on. So you see this is a right homonymous synopsia. So they cannot see on the right. And you're gonna, if you put a prism on, this will reflect onto the left visual field, which is right here. So basically you're increasing the left visual field that would be processed by the unaffected occipital lobe. So they use this. But you need to wait three months at least before a neuro-ophthalmologist will consider you for that. Central post-stroke pain, burning, usually spinothalamic, thalamus, projection on the primary sensory cortex. We tend to use medications that modulate pain signals in the brain, tactile desensitization for people that have allodynia, Elavil, fluoxamine. I use a lot of Lyrica, and there is good evidence for that. I don't like amitriptyline. It has strong anticholinergic side effects, and people end up with urinary retention and poor cognition on my stroke unit. So I tend to avoid that as much as I can. Lyrica is better from that side effect point of view. Take home, this is the last slide. Every time you have cross signs, think of brainstem, and the rehabilitation, the earlier, the more, and make sure to include the task-specific training. If you want to open a door, just do that task and open the door 100 times per day or even more, and that will improve your function with the same physical impairment that somebody has. I am done. Some references and a list of references. That's it.
Thank you very much, Dr. Fellew. We have a few minutes that we can open for questions. We can use the chat, or if you would prefer, please just ask your questions to Dr. Fellew. We'll give it a couple minutes to see if there's any questions.
I still don't see myself, but I think you guys see me, right?
I can still see you. Thank you.
Something happened. That's okay.
Can I ask you a question?
Yes,
Go
please.
ahead, Purvi.
Yeah, so I have a question that, sometimes at our organization that physiatrist is not, referred in the initial phase. I would say it would always beneficial in regards to, because we don't want it to wait until the patient started like the flaccid or the completely dense stroke started getting some tightness, increase in tone, and then you ask the physiatrist to see. What is your best practice says that as a stroke order set, it needs to be ordered just as a first assessment, initial assessment, or you have to wait till the symptoms start developing?
Are you asking about spasticity in general?
Yes, increasing in tone or the spasticity or any other medication, your expertise that can help a patient to reduce some of the other symptoms, which can help with the therapy participation.
So I can answer with two statements. The first one is spasticity in general appears in people that have profound weakness on one side of the body. So the moment we see somebody has profound weakness, then we monitor them from going through those stages of brainstem recovery, and stage 3 is the one that has most of the spasticity. If somebody is in stage 4, we're not worried about it because most likely they will continue to progress and their spasticity will decrease as the time goes by. But if you're on stage 1 from the beginning, which is flaccid paralysis, then we tend to monitor. And spasticity in general tends to peak within the first month of the stroke. But it can peak up to 1 year after stroke. And so the rule of thumb is if it hasn't happened within a 1 year because the person has stayed in stage 1 for 1 year and never moved up the stage 1, and I have a patient right now on my unit who is 3 months, I think, then it is unlikely to move from stage 1 to stage 2 where they get a little bit of tone. So the first statement is we need to know where they are in their brainstem recovery stages, and we can have an idea about whether they will develop significant spasticity or the risk of developing significant spasticity or not. The second statement, I do not know how where you work or how your rehabilitation team is working with the acute side, but here at the Regional Rehabilitation Center, we have a dedicated stroke unit, a rehabilitation stroke unit, which is a high intensity, shorter duration rehabilitation unit. And the physiatrist is the most responsible physician. I think they're in Toronto, they have a hospitalist who is the MRP on, for example, a stroke unit, and the physiatrist is the consultant. So basically the physiatrist will see those people on a regular basis, whether you are the MRP or not the MRP. I do not know where you work, but I do believe that having somebody with an expertise in stroke rehabilitation, like a physiatrist, would help your unit significantly with those physical impairments that may appear post-stroke. So yes, in other words, consulting with a physiatrist is good for the patients as well as for the unit.
Okay, sounds good. Thank you so much. I work at the Halton Healthcare. We have a designated stroke unit, but it's similar to Toronto. Have a hospitalist and then physiatrists come as on a consultation basis. But, you know, sometimes it hasn't been identified if, you know, we don't recommend, but then as you said, it would be really good to have physiatry on a team on a regular basis. So thank you.
Yeah, no problem.
Dr. Fellier, would I be able to ask you just to stop sharing your screen so we can wrap up?
Sure. Let me see. So stop share.
Just conscious of the time. So thank you very much for a wonderful presentation. Both the linkage with what Dr. Salas had presented, but then taking us further from the rehab perspective and putting it into clinical practice. So knowing that we had a very interdisciplinary audience, I think it really hit for everybody. You crossed all of those clinical pieces. So really appreciate that. In closing today, I would like to bring to everybody's attention that we do have an evaluation. Barb has sent out the link, so we would ask everybody to please complete that evaluation. I would also like to bring to your attention as we continue our series in post-circulation stroke, our next event is scheduled for November 2nd. It will be part 3, again from 12 to 1:30. And we have Dr. Mary Warren from the University of Alabama, Birmingham. And she's going to present on hemianopsia, the hidden impairment following post-circulation stroke, the functional limitations, assessments, and interventions. And that is available on our education calendar for people to register. So again, as you had brought up, all of the visual impairments and the hemianopsia, we'll do a deeper dive in part 3 with Dr. Mary Warren. So again, today, I would like to thank everybody for the opportunity to present today. Also, again, to thank our planning committee. As you can see, it's a vast group of people who bring their energy and their expertise to provide the presentations in the series to you today. Also showing you some of the other sessions that we have in our series. We have 6 parts, so we hope to be able to see you all join us again as we continue these series. So thank you, everyone. And I think we can draw today to a close, as I think we are exactly at 2 o'clock. So excellent. Thank you again, Dr. Fellier and Dr. Salas, and to my education committee teammates for providing for today. Stay well, everyone, and hopefully see you on November the 2nd.